Hi, this is Dr. Buhler, and I'm going to be providing a review of the sex hormone pathways. You're going to have had some of this information already in undergrad and in A&P, but that information is probably not at the level of detail that you're going to need to understand the pharmacology. So even if you know you've had this, please go ahead and watch through, and hopefully at the end of this you'll be much more prepared for the pharmacology lecture. The first half of the lecture today is going to be on the hypothalamic pituitary gonadal pathways. So these are the pathways that create testosterone, progesterone, and estrogens. When we talk about hypothalamic pituitary pathways, we actually have a lot of different ones that we've talked about. We talk about cortisol, we talk about thyroid, growth hormone, and we often teach these as if they're different pathways. But in reality, they all have the same structure. And if you can learn that structure, then you can just plug in the different hormone-releasing hormones, the different hormones that are involved in each individual pathway, and you can understand them without having to memorize everything all over again. So with that in mind, I'm going to start by talking about a generic hypothalamic pituitary hormonal pathway. And this should be the one that you could plug anything into this if you understand this. So we start with the hypothalamus, and it's going to release a hormone. That's the beginning hormone, and that's going to be hormone A. That's going to go through the bloodstream to the pituitary and act at hormone A receptors in the pituitary. Now, I'm talking about hormones that are being released in the bloodstream. You know that there are also ways that the hypothalamus activates the pituitary through neurons, but we're going to talk about the hormone release pathways that go through the blood itself. So that's hormone A. That's always going to be the first one. The pituitary is always going to then respond to this by releasing hormone B. Hormone B is also going to go through the bloodstream, and it's going to go to what we're going to call a primary target tissue. And this primary target tissue is going to depend on which pathway we're talking about. So if it's an estrogen pathway, the primary target tissue would be the ovaries. If it's a thyroid pathway, then the primary target tissue would be the thyroid gland. So we're looking here, and we've always got hormone A from the hypothalamus, hormone B from the pituitary, and then the target tissue, primary target tissue, is going to release a third hormone, hormone C. That's then going to go to our final, through the blood, to our final target tissue, which we could also call our secondary target tissue, which has hormone C receptors. And up here, I'm going to have the secondary target tissue. I'm going to clarify that that has hormone B receptors. And so it's the action of hormone C at those final tissues that are going to have the end effect. So if we're saying the growth hormone pathway, growth hormone itself is hormone C, and any tissues that have growth hormone receptors are going to be those final target tissues. With every hormonal pathway, you're going to have negative feedback because you don't want to continue to release more and more and more. And so every type of hypothalamic pituitary pathway is going to have this. When you have hormone B, you're going to be able to go back to the hypothalamus and inhibit more release of A. And hormone C is going to be able to go back to the pituitary and the hypothalamus and inhibit A and B. So we're going to have this ability to go back and feedback inhibit. So now we're going to talk specifically about the pathways that are involved in male and female reproductive hormones. And just because colors help me remember, we're going to be silly, and I'm going to use pink for women and blue for men. And we're going to start here with the female reproductive pathway. We're going to start with the hypothalamus. And this is the very, very simplified version. We'll go in the next slides and talk about the more specific things going on. But the hypothalamus is going to release hormone A, which in this case is gonadotropin-releasing hormone. That's going to act at the pituitary, and that's going to release hormone B, which is either follicle-stimulating hormone or luteinizing hormone, depending on the timing of the month. That's going to then go to our primary target tissue, which is going to be the ovaries, and they're going to release hormone C, which would be either estrogen or progesterone. And that is going to go through the bloodstream to our final target tissues, and those can be anything that's going to respond to estrogen or progestins. So we have breast tissue, we have neurons, we have skin cells, we have the endometrial lining in the uterus. So anything that's got those receptors on them, that's going to give us what we consider our final physiological effects of those hormones. We're also going to be able to have estrogen and progesterone inhibitory negative feedback to come up and alter and reduce release of GnRH, FSH, and LH. So the male cycle, also very simplified, we're going to do over here, and it's basically the same cycle as the female cycle with really very few differences. So we have the hypothalamus. It's going to release GnRH because the body didn't need to go ahead and create an entire new cycle and pathway for men and women. It just uses the same pathway and then changes what hormone C will be. So the hypothalamus releases GnRH. That acts at GnRH receptors in the pituitary, which releases FSH and LH. That then goes to the primary target tissue, which in males is not going to be estrogen or is not going to be ovaries, but is going to be the testes. So there's different types of cells in the testes that we'll talk about that have receptors for FSH, LH. And then the testes are going to release hormone C, which of course for males is going to be testosterone. Testosterone goes through the bloodstream to the final tissues. And those are going to be anything with testosterone receptors. We think about the testes themselves are going to have testosterone receptors for making sperm. We're going to see receptors in the muscles, in neurons, in hair follicles, anything that, again, is going to give those final physiological effects of testosterone. So if you look at this pathway and you look at the hypothalamic to pituitary to primary target tissue to secondary target tissue pathway, then you can see that in reality, if you understand that, you can plug in any of these hypothalamic pituitary hormones. So for the sex hormones, which we talked about right now, we talked about testosterone's effects, we will talk about testosterone's effects, testosterone, and estrogen and progestin. Those, we start with the GnRH release, go to FSH, LH. In the primary target tissue, we release the sex hormones themselves, and then they have their effects at the secondary target tissue. This is the same for all of these different types. So if you want to look at the cortisol pathway, it's the same thing. The hypothalamus releases, the pituitary releases, and then the primary target tissue, the adrenal cortex, is going to release cortisol, which now is acting at its secondary or final target tissues to have the cortisol effects. Thyroid hormone, same thing. Hypothalamus, pituitary, thyroid. Prolactin, we're going to have prolactin releasing hormone, prolactin itself, and then in this case it's a little bit different in that hormone C is not actually a hormone, it's milk that's being produced. from breast tissue that had prolactin receptors. And then we also have the same for insulin-like growth factors. So if you plug all of these in, you can look at each individual pathway as just an example of the general pathway. And one of the things that might help you here when you're trying to learn these pathways is if you look up here at the hypothalamus, the first hormone released is always RH. It's always the releasing hormone. And so that'll help you remember which one is being released at the hypothalamic level. So now we're going to talk about the male sex hormone pathway in much more detail so that you can see where these different drug targets are going to be. And then we'll talk about the female pathway as well. So we already talked about the generic GnRH to FSH-LH to testosterone. When the male pathway releases testosterone, it's doing so because of that initial activation in the hypothalamus. So the hypothalamus here is releasing GnRH, which we already said. But what's really important about the way that it releases GnRH is it has to be released in pulses. It can't be released at a steady level. And when we see that, I'm going to erase this real quickly. When we look at that, what we're seeing is that the hypothalamus is releasing GnRH every 2 hours. And it does that for males all month, every 2 hours, no matter what time of the month it is or what week of the month it is, because men don't have a monthly hormonal cycle. So this has to be released in pulses. These pulses are going to stimulate, they're going to go through the bloodstream, they're going to go to the pituitary, and they're going to cause release of FSH and release of LH every 2 hours. That's what the pituitary does when it gets those every 2 hour pulses of GnRH. If, however, it's not pulsing and you're getting inhibition, if it's not pulsing and you're getting constant levels of GnRH, and I'm confused because I'm trying to find my color here, and so you're getting GnRH like that through the whole time, then what's going to happen is the GnRH receptors on the pituitary are going to sense that they're getting constantly activated, and they're actually going to inhibit and no longer release FSH and LH. So this is an important thing in terms of pharmacology, in that if you want to release FSH and LH, if you want to give GnRH, you would have to give it in pulses. You couldn't give it as a steady concentration. If you did give it as a steady concentration, then what you would do is you would inhibit FSH and LH release. And we do that sometimes when we want to stop this hormonal pathway. So now we had that GnRH release. That went and acted at GnRH receptors on the pituitary. And those receptors cause the pituitary to release FSH and LH. FSH is going to go and bind to its primary target tissue. And its primary target tissue are the Sertoli cells in the testes. So over here I'm going to circle the Sertoli cells. They're within the testes themselves, and they're the cells that begin spermatogenesis. So the female has eggs from birth. Males have to create a sperm every day. So that's a two-stage cycle, and the Sertoli cells are going to begin that cycle for creating sperm. Luteinizing hormone, then, which is also going to be released from the pituitary, is going to go to a different target tissue. It's going to go to these Leydig cells to produce testosterone. And so this is the primary target tissue for luteinizing hormone, are these Leydig cells. And they are then going to create hormone C. And testosterone here is our hormone C. GnRH was our hormone A. FSH and LH were our hormone Bs. And now we have testosterone being produced. Testosterone is going to then go through the body, through the bloodstream, and it's going to go to a couple of different places. It's going to go to its final target tissues, and it's going to go and do negative feedback inhibition. So it's going to go up to the hypothalamus, and it's going to go to the pituitary and tell them to start to shut down, not to shut down, but to decrease production just so that you have a constant level instead of everything continuing to go too high. Because if your testosterone levels go too high, that creates disease and physiological problems just as much as having testosterone levels that are too low. So the testosterone, hormone C, is going through the blood, and it's binding to any tissue that has testosterone receptors. And so when we talk about the effects of testosterone in the body, we're going to see that we have receptors on muscle, like I said, on hair follicles, bone, neurons, all sorts of things. And any of the effects that we consider as testosterone-based physiological effects are going to be because those tissues have those testosterone receptors. One of the tissues that has testosterone receptors are the Sertoli cells. So these guys are going to have testosterone receptors, and the testosterone made from the Leydig cells is going to come over here. Now, the Leydig cells the Sertoli cells, I want to make sure I get this right, started spermatogenesis. So they began the process of spermatogenesis. But they can't complete it until they have testosterone. So Sertoli cells started spermatogenesis, and then the Leydig cells made testosterone, which came over and lets the Sertoli cells complete spermatogenesis. So without the testosterone, you won't be able to get the final maturation of the sperm. So at this point, like I said, the testosterone is also then going to go back and be able to feedback inhibit. So to summarize that, we had hypothalamic release of GnRH. It has to be pulsatile. If it's not in pulses, it will actually inhibit FSH and LH. If it's in pulses, then it's going to stimulate the pituitary to release follicle-stimulating hormone and luteinizing hormone. Follicle-stimulating hormone is going to go to Sertoli cells and induce them to begin spermatogenesis. Luteinizing hormone is going to go and bind to receptors on Leydig cells and induce those to produce testosterone. That testosterone is going to go to a lot of different tissues, all the different testosterone-dependent tissues that we think of as testosterone sexual male type of tissues. But it's also going to go back to the Sertoli cells. And when it hits those Sertoli cells, now that's going to allow spermatogenesis to be completed, and we're going to have those final effects of testosterone. Now, when we go to the female sex hormone pathway, it looks very, very similar. The only difference that we're really seeing in the female sex hormone pathway is that we have a change in the cycle over the month. And so in males, you have gonadotropin releasing hormone in about a 2-hour cycle the entire month long. Women are going to change the pulse frequency of gonadotropin releasing hormone through the month, which is going to actually switch us back and forth from follicle-stimulating hormone and luteinizing hormone. So when we begin that, we look again at gonadotropin-releasing hormone being released from the hypothalamus. It's being released here in a slow pulsatile manner, and when the pituitary sees slow pulses of GnRH, that tells the pituitary to secrete FSH. Again, if you're not pulsing, if you're getting a constant level of GnRH at the pituitary, it inhibits release of FSH and LH. So the same as with males. But in terms of inhibition by chronic. But in females, that slow pulse is only causing FSH to be secreted. That FSH is going to go here, I'm going to draw it out here, is going to go to its primary target tissue, which are going to be ovarian follicles. I'm going to draw some follicles here. And the ovarian follicles are the structures around the eggs. And so the follicles will have to mature in order for the eggs to be mature to be ovulated. So FSH is going to then bind to those FSH receptors on the ovarian follicles, and that's going to induce these follicles to mature and hopefully only induce one to mature so that you have only one egg released each month, sometimes two. If you have multiple follicles maturing and ovulating, then you could have multiple births. But we're going to bind to those ovarian follicles, and we're going to cause them to start to mature the eggs, but we're also going to cause those follicles to produce estrogens. So GnRH is here our hormone A, FSH was our hormone B, and estrogen was our hormone C. The estrogens are going to now go and act at the final target tissue, which in females are going to be anything that we associate with the female sex hormones, the uterus, the breast, neurons, all sorts of different things. And those are going to also go back and feedback inhibit the pathways so that you control your GnRH, LH, and FSH release. One of the things that estrogen is doing here that's very important in terms of this cycle is it's inducing the buildup of the endometrial lining in the uterus. So at this point, your FSH has caused the ovarian follicles to start to mature, and they're producing estrogens, and that's building up the endometrial lining. And the endometrial lining is that blood tissues, capillaries, and endometrial cells that are going to be preparing the uterus for implantation of a fertilized egg. So here, let's go back to the effects of estrogen here. We have building of the endometrial lining, affects at all sorts of other tissues, and feedback to the hypothalamus. At this point, that feedback to the hypothalamus of estrogen is very critical because it is going to tell the hypothalamus to to increase, to make the release of GnRH more rapid. So when we started out, we had the slow pulses that stimulated FSH release. Now you've got fast pulses, and those are going to now switch the pituitary over to releasing LH. So now you've got LH release. LH, or luteinizing hormone, is going to then go and bind to luteinizing hormone receptors on the ovarian follicles. And the ovarian follicles have already been matured because of the FSH. Now they're just waiting to release an egg. The LH binds to those follicles. That induces them to ovulate. So here's a little egg being released. And it changes the types of hormones that those follicles are releasing. So we've got ovulation, and we've also got those ovarian follicles now producing more progesterone, as well as continuing to produce some estrogen. This is important now because now you have progesterone on board, as well as estrogens. And while the estrogen work to build up the endometrial lining, the progesterone retains it. And so when you're waiting to see if a fertilized egg is going to implant, you need to retain that lining instead of shedding it through a menstrual period. So we're waiting here. Progesterone is being released by the ovaries, and as long as that's there, that lining stays. At the end of the menstrual cycle month, if no implantation has occurred and no pregnancy has occurred, then the progesterone levels are going to drop off and the endometrial lining can be shed. And that would be just your standard normal menstrual period. So to review that again very quickly, the female sex hormone pathway, you start with the hypothalamus, slow releases, impulses of GnRH, activate the pituitary to release FSH, and the way to remember follicle-stimulating hormone is you're stimulating the follicles, and those were the follicles in the ovaries. So that's going to be always the first one, and that's how I remember it, is it's stimulating the follicles. That's causing the follicles to start to mature, to create eggs and follicles that are mature to be ready to release, and it's also causing estrogens to be produced. Those estrogens are going to multiple final target tissues, including the endometrial lining. The estrogens that were released were also going back to the hypothalamus and telling the hypothalamus to switch over and change its GnRH release to be a rapid or fast pulse. When the pituitary gets that GnRH at that fast pulse, it tells it to release LH instead of FSH. The LH binds to those same ovarian follicles and tells them now to release the egg and ovulate. It also tells them to start making more progesterone. That's important at this point because at ovulation, if you've had fertilization of the egg, you no longer need to build more endometrial lining, you need to retain it. So that progesterone is going to retain the lining, and if a pregnancy occurs, you're going to keep your progesterone up, that lining is going to stay there so that the fertilized egg, which is implanted, can have a good environment. And if no pregnancy occurs, the progesterone is going to drop, and you're no longer going to retain that lining, and menstruation will occur. So I hope that helped to understand the receptors that are involved, because we're going to have drugs that act at FSH receptors, LH receptors, GnRH receptors, testosterone, progestin, and estrogen receptors. I do want to make it clear that what I've told you here is all extremely simplified. When you look at these pathways, I've left out some extra hormones like inhibin. I've left out a lot of feedback loops and a lot of timing issues. And that's really because we're trying to just bring it down to what you need to know to really understand the drug actions here. And these pathways are really so complicated. If you want to know a lot more about them in detail, I encourage you to go ahead and look up the literature. But I think this will be enough for us to get started with pharmacology soon.